today is I'm going to ask you questions, and I'm going to push the people sitting to contribute to the answers and things rather than me do a tutorial. The first thing I want to cover is sensitivity and specificity, and sort of, I guess, the way that diagnostic testing is discussed in the papers and textbook and things like that, and some of the, I guess, things that potentially pitfalls. Like when I was studying, I was like trying to learn exactly what the sensitivity and specificity was for each test, for each disease, and it's just unrealistic because it differs from lab to lab and technique to technique and things. So it's actually not, the actual numbers aren't as important as understanding the methodology. So I just wanted to run through that stuff to give everyone a bit of background on that. Has anybody studied the sensitivity and specificity already, or are we waiting?
I've studied it, but not each individual test, just kind of what it means.
Yeah, good, excellent. So essentially, you've probably all seen this very busy box, which describes what sensitivity is, what specificity is, what a positive predictive value is, and what a negative predictive value is. So just to sort of summarize the box, up the top is whether the patient actually has the disease or not. So based on gold standard testing. So say if we're talking about leptospirosis, for example, and we've done the MAT, the microscopic agglutination test, and that's come back positive, that's considered the gold standard of lepto testing. So if the patient has the condition and we did a lepto PCR and it came back positive, it would sit in the true positive box. If that came back negative, but the patient actually had the condition, it would be a false negative. So sensitivity, when we say it has a sensitivity of 97%, that refers to the number out of 100 of true positives that you're going to get. And so then for every 100 tests you run, you're going to get 3 false negatives in patients that actually have the disease. Does that make sense?
Yep.
And then for patients that don't have the condition, if we've got a very specific test, then we're going to get 97, 98% negative results when we test those patients. And then 2% are going to come back positive, even though the patient does not have the condition. So sensitivity and specificity refer to the true disease status. So if they have the condition, then, or whether they don't have the condition. Whereas the positive predictive value and negative predictive value refer to the test result. So if they test positive, do they actually have the disease? If they test negative, do they actually have the disease? So I find the easiest way to comprehend this, because I literally have gone through this probably 100 times and I still forget it and still catch myself using the wrong wording and things like that. And obviously in an exam, it's really important that the words that you write down are accurate, because you won't have a chance to clarify. So I wanted to run through a couple of examples, and I'm gonna do the first one, and then I'm gonna get you guys to do some. So I want to talk about the human coronavirus test. So the coronavirus swab has a sensitivity of between 71 and 98%, depending on the lab that's running it. Oops, sorry. So I'm going to write in here. I don't know why this isn't working. Sorry, bear with me for a sec. We're in slow motion today. There we go. guys see my cursor?
No.
No, me neither. It's gone missing. I'm just going to close the presentation and restart it. Danielle? Sorry, I don't, oh my gosh, it's just come back. Okay, amazing. Phew, I don't know why. Okay, so the human coronavirus testing, depending on where it's run, has a sensitivity of 71%. So if we write in here that out of every 100 tests we do, 71 of them are going to test positive when the patient has the condition. That means 29 people are going to test negative even though they have the condition. The specificity of the human coronavirus test sits around 95%. So when you get a negative result, it's 95% chance that it's really negative and a 5% chance. Oh, sorry. When the patient doesn't have the condition, there's a 5% chance it's going to test positive anyway, and a 95% chance it's going to be a true negative. So what do you then sort of thinking about applying this test to a population where the disease is really not very prevalent? So, for example, in Australia, where tens of thousands of people are getting tested every day, but we're getting 2 to 3 cases. What sort of, can anyone make any comments about how many sort of false positives we're going to be getting in that population, or whether we should change, whether we should be sort of selecting a test that's more sensitive and less specific, or more specific and less sensitive, so that we're catching more? I've worded that really badly. Sorry, everyone. So what I'm trying to get at, like the impact on the human population, the Australian population, of a test coming back positive when the patient doesn't actually have the disease is quite big, right? Like they go into quarantine, everyone they know goes into quarantine, everyone gets tested and things like that. So you really want to have a really specific test. On the flip side of that, the impact of getting a false negative, which theoretically we could be getting 29 times out of 100 when a patient's actually positive, has even bigger impact on the population. So where you've got really low prevalence of disease, you want to have really, really sensitive and really, really specific tests, because the impact of, you'll get 29 false negatives out of 100, and the chances of you actually missing a patient is quite high. So if we, oh, my cursor's gone away again. If we then, I'm going to give you guys a couple of numbers. So is anybody happy to volunteer to draw? Max is nodding.
Yeah, I can do
Okay,
that.
super. So the test that I want you to look at, Max, is the canine pancreatic lipase test, which has a sensitivity between 21 and 90%, depending on which lab we're looking at. So let's go 50, somewhere in the middle.
Yeah.
And a specificity of around 80. My cursor's gone. Will it let you draw?
Yeah, I think so, yeah.
Okay, cool. Do you reckon you can erase my numbers?
No, I don't think I can.
Okay, no worries. Sorry, I'll just wait for my cursor to come back to life. Here we go. Okay, go for it, Max. So we're going to go 50 and 80. 50 sensitivity and 80 specificity.
Like that.
Beautiful. Okay. So in a disease like pancreatitis, does it really matter if we're getting false positives?
No, not really. Yeah,
Not
we got a
really.
lot of.
It's not infectious. So it's not like we're going to quarantine that patient, for example. What about if we get false negatives? Is that a problem with this disease?
Yeah.
So I think it's interesting that we've got for pancreatitis, it's the best test we've got, but there's a lot of false positives and a lot of false negatives with this test. So obviously with pancreatitis, we treat symptomatically, and we're going to treat gastrointestinal upset the same or very similar way. But it's an interesting sort of observation on that test. Now we'll focus more on the infectious diseases from here on in. So we wanted to talk a little bit about leptospirosis because we thought it might be a hot topic for exams this year. So who can tell me one of the tests that we can do for leptospirosis?
Like a urine and serum PCR.
Yep, okay. So if we go PCR, which if performed in after 7 days of infection, has a sensitivity of 95% and a specificity of 98%. Max, can you type again? My cursor's gone.
Yep. Specificity was 95%.
98 for specificity. And then 95 for sensitivity. Awesome. Excellent. So all of these numbers are dependent on there being enough organisms to detect. So the trouble with a PCR and the reported sensitivity and specificity are that it depends on testing at the right time. So particularly with leptospirosis, can someone tell me how the disease unfolds? How is it contracted?
I think it's when they come into contact with infected urine.
Yep.
Generally, and then it kind of spreads through the blood before kind of, I think, having a host response, immune response, and then it has like a really special way, which I can't really remember my notes, but where it kind of hides and goes to kind of areas like the urinary tract, where it kind of hides from the host immune system and sheds from there.
Excellent. Good. So it goes through these phases where in the first phase, it's going to be present in the blood, but not in urine. So if you did a PCR, you get a positive on the blood, but not a positive on the urine or a negative on the urine. So obviously in that first week of detection, the PCR in urine has very low sensitivity. Is that right? Sensitivity? Make sure I'm using the right word. Yeah, so be much more likely to get false negatives. Yeah. Sorry. Whereas in the second week of infection, if you do a PCR on urine, then we're going to get closer to that 95%. Whereas if you did a PCR on blood in the second week, where the organisms are then hiding and not in circulation, then the PCR on blood is going to be much lower in the second week of infection. So then we know that PCR is flawed, and we know that it's all well and good to say 7 days after exposure we should be testing urine, but we don't actually know when these patients were exposed. So clinically, it's very hard to pick which test to do because you don't really know what phase of infection these patients are in. So other than PCR, what other tests are there for lepto?
Serology tests.
Mm-hmm.
So like your ELISA and your the MAT test as well.
Yep, excellent. So the MAT test was the gold standard for detection of leptospirosis. So that's sort of what's been written in textbooks up until the last 5 years, is that this MAT is the gold standard. But does everyone know what the MAT is?
Microscopic agglutination test.
Excellent. So it's an antibody test. The sensitivity, now that we've got other ways of detecting lepto, has actually been listed now as 67%. So Max, can you be my scribe? Sorry. So 67% for MAT.
67%, that's sensitivity.
Sensitivity.
67.
And then 100% specificity.
Yep.
Excellent. So if you look at kind of if you get a negative test for lepto using the gold standard, 33 out of 133 times, that's going to actually be a disease positive patient. So you can see that one test on its own for leptospirosis, particularly when you don't know how long they've been infected for, is not going to be adequate to detect it. And you're probably going to need to do a combination of both PCR and serology testing to get your diagnosis, or to rule out leptospirosis. Why is it so important to rule out leptospirosis?
Because it's zoonotic, so you want to make sure that they don't have it.
Excellent, good. So we want a really specific and sensitive test to know that if we get a negative, it's definitely negative. And if we get and we need a positive, if it's disease positive, it needs to be a true positive. What other tests are there that have been developed more recently for leptospirosis? They're serology-based tests or antibody detection tests.
Oh, like the witness test?
Yeah, good.
Yeah, so like the point of care test that Zoetis made.
Yeah, absolutely. So there's two brands. One is a SNAP one, and the other one's a witness one. Have you heard about the SNAP one or the witness one, or the difference between them?
I read one paper a while ago. I think it was either from IDEX or from Zoetis, and they were just shitting on each other basically. I can't remember which one it was, but the witness one sounds quite good.
It really does. So the difference is that the witness one detects IgM. Why would an IgM detecting test be better than an IgG detecting test?
That's because IgM is produced early in an infection, whereas IgG is produced more by memory cells.
Absolutely.
And so that's going to be later on in the infection or after an infection has passed.
Excellent. And tell me about that in the context of vaccination.
I can't.
No worries. How long lasting is the IgM response?
It's relatively short, but it also depends on, like, to make your B cells start producing or turn into IgG producing plasma cells, you generally need like more than one exposure or like a longer term exposure, I think, something like that. Whereas initially, no, I don't know, sorry.
No, that's all right. That's the answer I was after. So
Okay.
initial exposure, we get this spike in IgM and it's produced before IgG is. IgM response is quite short-lived and won't stick around for more than about 6 weeks or so. So if you get an IgG positive patient and not with no IgM positivity, it's probably not an active infection. It's probably lasting immunity from either previous exposure or vaccination. So the SNAP test, which detects IgG, will detect infection later in the course of disease and be more susceptible to cross-reactivity with vaccinated animals. So won't be as indicative of an active infection. Does that make sense?
So there is no use of an IgG test for lepto, basically.
Not really. Sorry.
Okay.
I don't want to get in trouble from IDEX, but
I won't tell anyone.
It's definitely not in the acute phase of infection. So they did a study looking, so they infected a whole heap of dogs with a whole heap of different serovars of lepto. And then they did all of the tests. They did the MAT, they did the IgM, IgG, and the PCR, and they looked at when they became positive. So the IgM one detected 100% of the patients by day 10, and that was the earliest of all of the tests to show up. The MAT detected 30 out of 32 by day 14, so nearly 100% by 2 weeks in. And the IgG test only detected 3 out of the 32 in that first 2 weeks. So that gives you an indication of how slow that IgG response.
Wow.
Yeah. So if I was faced with a patient, and we are all the time with acute renal failure, and I was suspicious that leptospirosis should be ruled out or ruled in, I would be doing EDTA blood and urine PCR, and I would be doing a witness IgM SNAP. Well, it's not a SNAP, sorry, lateral flow device. Because that's a point of care test. So as far as the way that we nurse these patients and care for them in our clinic, it's a really nice just kind of rule out, because we know it's going to be positive early in the course of disease as well. And looking at that kind of early in the course of disease positivity, it's actually got more accuracy than the gold standard test of the MAT, the microscopic agglutination test. So that's lepto. Is everyone comfortable with lepto testing? I should have asked you guys how you would test for lepto. All right, so moving on to Ehrlichia, which was the other one that we thought might be a hot topic because it's just been cropping up in Australia for the first time in the last year or so. So there's 2 different tests for Ehrlichia. What are they?
The IFA, I think from, the IFA and the PCR. I think
Right.
Set up.
Excellent. Have you heard about sort of, would you do both, or which one would you do?
I think depends on how it's presenting. If it's really early in the course of disease, you'd want to make sure you're doing a PCR over the IFA, but I guess you just do both to kind of be sure.
Yeah. I think the correct answer in this would be, this is a reportable exotic disease, and I would consult with the Department of Primary Industries.
Good idea. Call EMAI.
Yeah. So I think the answer would be both. So because we really can't afford to be missing these patients, so we need to make sure we're being as accurate as possible. And because this is a reportable disease, all testing's paid for by the Department of Primary Industries, so it's not a financial issue sending off all of the tests. But to make sure you do it through the, I think it's EMAI, Elizabeth MacArthur Agricultural Institute, who runs it. But if you just Google Australia Ehrlichia, if you've got a case that you're suspicious of, you'll come up with the instructions of how to submit testing. Probably not so much of a problem down in Tassie, Grace.
No, no, not really. There's a lot of things that like I'm just like, oh, haven't seen this in a while.
No, I've seen one case of, probably two cases of Ehrlichia, but one was euthanized and they didn't go ahead with testing, but it was pretty slam dunk. So what clinical signs would we be expecting in a Ehrlichia case?
Sorry.
Sorry, I was just saying we need Helen, who's
we do need Helen.
We work with. Sorry, Grace, you go.
No, you're right. I think they get like a generalized lymphadenomegaly and splenomegaly. And they can also have like bleeding tendencies as well, so like petechiae and ecchymosis, along with like a generalized being unwell, vomiting, lethargy, diarrhea, etc.
Excellent.
Fever.
Good. Who said that? Was that Sam?
Yeah, I lived in Belize with 100% Ehrlichia.
Sorry?
I lived in a country that every dog had Ehrlichia.
Really? In Belize?
Yeah.
Wow. What other clinical signs do you see?
I think it can look like everything. It can look like coughing, nosebleeds, back pain, lymphadenomegaly, splenomegaly, general malaise, petechia, ecchymosis, chronic weight loss, everything.
Everything. And I think that's a really important point with this disease. It causes really profound immunosuppression. So I always say, you know, Josh is pretty used to me saying in the clinic, we need to find one disease to explain all of these problems, because the chances of there being two diseases are pretty slim. But this is one exception to that, where if the clinical signs don't fit 100%, test anyway, because they might have discospondylitis from the immunosuppression, or they might have pneumonia from the immunosuppression. So there's this and Addison's. There might be two diseases present. So if I was to ask you an exam question on what hematologic abnormalities might you expect in a patient with ehrlichiosis, what would your answer be?
Anemia, thrombocytopenia.
Excellent, good. So 100% of patients have thrombocytopenia.
Yeah.
Excuse me. So they might have a neutrophilia, but they might have a neutropenia, and they might have normal neutrophils, depending on whether they've got a phase of kind of reactivity. And they might be anemic, depending on the chronicity of disease. You might have an anemia of chronic inflammatory disease, or you might have a regenerative anemia associated with a bleeding tendency. So they're sort of things you might see on hematol. What about ultrasound?
Like splenomegaly.
Good.
As Sam said.
Yeah. So that case that we saw recently at Northside, it had a really spotty looking spleen on ultrasound. So lots of hypoechoic nodules right throughout the spleen. What historical information would you want to get if you're suspicious?
Where the dog has been in the past, like has it come from the Northern Territory?
Yeah, exactly.
Or North Queensland.
Yeah, exactly. Yeah. So there was a study fairly recently, like 2014 or so, they just went around and sampled dogs in rural communities in Northern Territory, Southeast Queensland, and they actually didn't detect Ehrlichia in that study. So it's emerged since then. So it's a fairly recent infection.
The dog you saw, Anna, where did it come from?
Beg your pardon?
The dog that you saw, where did it come from?
Northern Territory. So the clients had rescued it from an agency that had got them from the Northern Territory. Sorry, I'm just going to tell my dog to be quiet. Sorry, one sec. Sorry. Yes, Northern Territory, Jeff. And the other one that I saw had been acquired from a rescue agency, but of an unknown origin. So I'm assuming that it was Northern Territory as well.
The lesson there is that we can see it in Sydney.
Absolutely. And I guess the worst thing would be if it got into the tick population in Sydney. So the more we can sort of detect these patients before they've had a tick attached to them, the better. Tell me about transmission of this disease and why our current tick preventatives won't prevent transmission of Ehrlichia.
Is it because a lot of the preventions that we're using now require a tick to kind of bite and put on, so they can transmit it that way still?
Yeah, exactly. So the tick only needs to attach to transmit it. It doesn't need to be on for any period of time. So all of the preventatives that help with Ehrlichia transmission are preventatives that deter ticks. So things like Advantix, permethrin, that have a deterrent effect. But again, then not as good at avoiding tick attachment and then tick paralysis, as well as the newer Brevecto and NexGard style of medications. So a little bit of a compromise there. All right, so I'm going to move on. Is everybody happy with sensitivity, specificity, positive predictive value and negative predictive value? Yeah, cool. Oh, it's so frozen. I don't know why. Right. You'll have to bear with me. The other infection that I thought we should talk about is actually FIP. Why might FIP be a hot topic at the moment?
Because of coronavirus.
That's not what I was thinking, but yes, that's true.
Because of new drug?
Yeah, exactly. So this is the first time in years there's been any reasonable treatment options for cats with FIP. What is the new drug?
Remdesivir. Or is it?
Good.
That's the one, yeah.
Excellent. Have you guys done a bit of coronavirus study?
Yeah, I've done a little. I think Max has too.
Excellent.
Sorry,
Good.
Max, I dubbed you in.
Okay, so because we're talking about diagnostic testing, what are the limitations of a fecal PCR detection of coronavirus?
Oh, because you don't know if, even if it's positive, you don't know if it's the cause of the FIP.
Yeah.
Because I think what 97% of the care will get like the enteric coronavirus.
Exactly. Yeah. And they can be chronic shedders, so just carriers of the organism, or they can test positive after a live vaccine. So there's a few sort of limitations of PCR testing of feces for coronavirus. Now, in the context of having a cat with suspected FIP, a positive fecal coronavirus, it helps you say, okay, they've definitely been exposed, so that we're definitely at risk. But it doesn't actually help you to make a diagnosis of FIP.
Is there any way it helps you make it lower on the differential list if they're just not shedding the? Do you get what I mean? If you don't find it.
Fecal coronavirus. So if that came back negative, I couldn't say they've never been exposed to coronavirus or they weren't exposed because
as a
FIP
kitten,
can develop up to a year after exposure.
Yeah.
Okay. Are you laughing at my dogs, Josh? Sorry, they're so noisy. So what test could you do to determine whether a cat's been exposed to coronavirus and help you rule out FIP?
There's the is it reverse transcriptase PCR? Is that what it's called? It's RT-PCR. That's all I remember. That's a really
good. That's a really good test to detect FIP, but to rule out FIP, there's a test that would be.
Oh, like immunocytochemistry or immunohistochemistry? Oh, sorry, you mean that's to diagnose as well. Sorry, I'm not sure.
I'm trying to work out where this sits in the sensitivity and specificity. Tell me about antibody testing for coronavirus. Can you make a diagnosis of FIP if they test positive?
No.
I don't think so, no.
Because if they have been exposed to any coronavirus or feline coronavirus, then they can be positive.
Okay, and what about if they test negative?
Sorry?
What about if they test negative? If you're suspicious of FIP and you do an antibody test, serology, and they test negative?
Then it's unlikely that they've got coronavirus because otherwise they have antibodies.
Very unlikely that they've been exposed to corona. Yeah.
What about if it was recent exposure? Could they test negative?
If it was recent exposure, they could definitely test negative, but they wouldn't have FIP yet.
Oh, yeah. Makes sense.
It takes a while to develop. My thing's still not working. So annoying. Oh, here we go. It's just not letting me stop sharing. Can you still see my screen?
Yes.
Yep.
Yeah.
Damn it. Oh well, moving on. I had a whole heap of questions that I really wanted to ask you. Okay, I might be out. Hey. Oh, thank you, Danielle. You're a lifesaver. Okay, I'm just going to read out the questions now because I don't dare try and share my screen again. So moving on to testing. I want somebody to tell me 3 ways to detect microorganisms. Very general question.
Like a culture, sample PCR.
Yep.
And light microscopy.
Very good. Exactly the 3 I was after. Does anybody think of any others? They're really
microscopy.
That's what Max said. Yeah. Did you say light microscopy?
Yeah.
Yeah. And I guess the only other one would be like electron microscopy or something like that, which would help you detect viral organisms. But obviously light microscopy is really important, and that's either cytology or histology. So discuss the advantages and limitations of culture?
The advantage is if you culture something, then it's very likely to be a true positive. Whereas if you don't culture something, doesn't mean it's not there. There can be some things that are quite difficult to culture.
Absolutely. What might some examples of that be?
Lepto is a good one. It takes like 6 months to culture.
Yeah.
I think. And I think things like mycoplasma and all that are really tricky to culture as well. So.
What about viruses?
Viral culture, you need cells to culture them in, which does make it quite difficult, and the cells are generally pretty flimsy at living.
Yeah. And you also need to culture viruses really to know what virus you're trying to culture, to know what cells to put it in and things like that. So you almost need to know what the diagnosis is before you do the culture. So culture is quite limited for any organisms other than bacteria and fungi, and even fungi are so slow growing that there's limitations as far as making diagnosis and using that to guide treatment. Excellent. What about the limitations of PCR?
So with PCR, you need enough DNA there to actually be able to amplify it. And the organism needs to be present in the thing that you're running the PCR on. So like with lepto, if you're running it on urine, but it's not in the urine yet, you're going to get negative.
Excellent.
But if you get a positive.
Excellent. The other one that I wouldn't expect you necessarily to get, but something that's worth considering, is there's a lack of standardization of the primers that labs are using with PCR, and also like the sensitivity and specificity as a result of the difference in techniques between labs. So where in one lab you might get a sensitivity and specificity close to 100 for a certain organism, you can't necessarily extrapolate that to another lab. And so your testing just might be a little bit less accurate than you're anticipating. And the other thing is, say you've got a patient with Ehrlichia and it's been on doxycycline for 3 weeks, and you do a PCR for Ehrlichia, what's it going to come up as? Do you think
Negative?
positive?
Probably negative.
Actually probably going to be positive. So for PCR detects dead organisms as well as live organisms. So whilst that's potentially an advantage in that we can still get a positive result, even like you don't have to delay treatment while you're getting samples, that can also be a limitation as far as determining whether there's still active infection. Does everybody understand exactly what PCR is?
Yeah.
Yeah, excellent, good. If not, go on YouTube. There's like several really good 5-minute videos that you can just animates the process basically. Okay, next question. What do IFA, ELISA and Western blot tests detect?
Antibodies.
Excellent, very good. Do you know how they work?
Kinda. The ELISAs, when they kind of have all those many wells with where they get patient, and in the wells there's antigen. So they get patient serum and dilute it to many different dilutions, and then pop it in those wells, and then kind of wash it, and then put like something in there that makes, if those antibodies bound to the antigen, colorize, and then they look at the colors, and if they can detect the color, it means it's a positive. So depending on kind of how dilute they get the sample to, that's how they report the results.
Awesome.
And IFA is kind of similar, I think. I think it's like just one well.
Yeah, so it's sort of one step.
And I don't know what the Western blot is.
Hey?
I don't know what the Western blot is.
So the Western blot, it's like uses electrophoresis to kind of run serum up a like detection line. Have you seen those pictures of they're like really grey and white pictures, and they're got all these kind of lines, and then you might have like 3 positive lines on one of the patient samples kind of thing.
Oh, like when they do it with like DNA, electrophoresis, that kind of thing?
Similar, yes, it is similar. So it's with the Western blot, you can detect multiple antibodies in the one test, whereas with like ELISA and IFA, it's kind of one test for one organism sort of thing. Whereas with a Western blot, you could say, I want to detect all of the mycoplasmas and I want to detect which one we've got antibodies to. And you might be able to sort of detect that there's 3 different mycoplasmas or mycoplasma antibodies in that sample. So it's just a little bit less specific than ELISA. And see, again, I'm using the wrong word. So specific's the wrong word. Western blot is you're casting a broader net and you can test for more things at once. So again, it's just antibody detection. But they tend to use a Western blot in, like, for example, lepto, where they want to differentiate species that the antibody reaction is to. All right. So next question is, describe the limitations of antibody-based testing for infectious disease in the following. And these are worth 1 mark each, so I'm not after a very long answer. But the first scenario is an 8-week-old puppy.
Well, because of the maternal antibody.
Excellent. Yeah. So if you got an antibody positive result, could you say that that puppy was infected with anything?
No.
No, exactly. So it may have been that mum had been exposed. At what age do maternal antibodies predictably wane?
16 weeks.
Did someone say 16?
Yeah.
Yeah, perfect. So that's the cutoff. So that's where the sort of vaccine recommendations come from. The last vaccine should be after 16 weeks of age, because you can almost guarantee that the maternal antibodies won't block the vaccine response from that point onwards. So if you've got a patient older than 16 weeks, you can say, and they've got an antibody response, you can probably say that it's a true infection. Okay, scenario 2 is an IgG test 10 days after disease exposure.
No, because they're not going to have IgG yet.
Exactly, yeah. So 10 days is really that very earliest that we detect an IgG response in most diseases. And some diseases are really good at triggering immune responses. Others are really slow. So sometimes it's up to 3 months before we've got an IgG response, and sometimes never. Scenario 3, remember we're describing the limitations of antibody-based testing for infectious disease in a 1-year-old cat with suspected FIP.
Again, I think it's hard to interpret because they could have had a vaccination, they could have been exposed previously as well to just regular coronavirus.
Exactly. So it's not very specific for FIP. It's very sensitive, but not very specific.
And if it's in a cat household, even more so.
Yeah, absolutely. So do you know what the stats are on that? I think somebody said
probably like 100% or something.
Yeah, it's like 97 or something, really high.
Mm.
And last scenario is suspected toxoplasmosis.
So with you want to try and document that they have higher IgM titers, and if they do have higher IgM titers, more like suggestive of current infection. But if they have high IgG titers, then it may just mean there's previous exposure or infection that's kind of resolving. So you want to kind of repeat that test and document that it's increasing by 4 times. Excellent.
Over what time frame would you repeat that test?
I think by the time you get your first result, you probably wanted to start it again because it takes a few weeks. But, so a few weeks, I think, probably.
So 2 to 4 weeks, depending on which infection you're talking about. With toxoplasmosis, we normally do 2 weeks if we're concerned about an active infection. If IgMs come back negative, but the IgG is quite high, we want to document a rising titer after 2 weeks. And similar with lepto as well. If you do a serology test that comes back for IgG that comes back negative, do it again in 2 weeks' time, and much more likely to be positive. All right. So we've covered most of the things I wanted to cover. Have you guys got any sort of specific questions about infectious disease that you want to cover before exams?
I need to write them down, Anna. I feel like I have so many questions that pop up when I'm reading these and then I forget them. So
Yeah. You do just need to have an A4 sheet beside your study page, like questions. Everyone happy then? We might wrap up. Oh, and neither of you were at the clinic. I get it.
No.
Everybody's off studying. So normally we have to wrap up in a hurry for everyone to go to rounds, but not today, but I still have to go to work. So we still have to wrap up.
Good luck, everybody.
Yes, good luck. We'll be thinking of you.
Thanks.
And Josh, if you think of any questions, just email them through to me.
thanks, Anna.
No worries.
Thank you.
All right.